so then to kick off our first session, we are, in my opinion, starting with the most important set of problems, which is mental health. And of course, that's my own specialty of psychiatry, so I'm biased. But as I never tire of reminding people, these disorders are also our single largest source of healthcare spending and our single largest source of disability. So they are very much something that has touched almost every life here in this room at one point or another. So today, we get to hear from three folks who are, in different ways, really revolutionizing what it means to treat a mental health disorder. And the first of them on the stage behind me is Dr. Heather Dawes from San Francisco, who, if anybody has ever exemplified the term neuroleadership, it's Heather, who started out in cell and molecular biology, but then has pivoted through a career in scientific editing, in working for philanthropy, helping to design programs, and then most recently as both a scientific and administrative lead at several projects in San Francisco to build next-generation neurotechnology and the national-scale organizing frameworks that let the rest of us then pick up their innovations and use them in our own trials. So she's going to talk to us a little bit about a specific application in depression, but I hope you'll get a chance to ask her about some of the things that their Wild Hub and their Open Mind initiative are doing that support us all. So please take it away, Heather.
Thank you. Thanks so much, Alik. That was far too generous an introduction, and thanks very much to you and the other organizers for the invitation. There were many reasons I wanted to come, but on the list was the fact I'm trying to visit all 50 states, and this way I get to tag on one of the stragglers. This weekend I'm going to Fargo, so I can knock off North Dakota. As Alik said, my background is varied, and I don't come here as a clinician or an engineer or even a neurophysiologist. I humbly represent a very heterogeneous group of specialists in our team, partly represented here. And I think in the spirit of using our day-to-day to discuss some of the arising issues in our field, I'll try not to dwell too much on data today and leave some time for discussion. So it's the first talk of the session. I'm going to keep it high level with respect to the complexity and challenges and importance of addressing neuropsychiatric disorders. I don't have to tell many of the people in this room how challenging these are from a clinical standpoint. Of course, they are and remain poorly understood, hopefully year by year becoming a little bit less so. Of course, a hallmark of these disorders is their heterogeneity across patients and even within our traditional diagnostic frameworks. There's a lack of objective diagnostic tests and accordingly major challenges in developing personalized, rational, objectively oriented treatments. And of course, some of the key factors in driving our confrontation of major depressive disorder are listed here, namely the severe disease burden worldwide and the limitations of current therapies, as well as the stagnant nature of new treatments over the last 10 to 20 years in this area. So if you're going to do neurostimulation to try and address major depressive disorder, there are a lot of questions that one has to ask. Where should one stimulate is only one of them, but it is a critical one. We continue to have a lack of definitive understanding of the underlying circuitry of MDD, but I think optimistically speaking, that is starting to improve over time. I think one of the biggest challenges that we'll probably hear about today and learn further as we move ahead in this area is the challenge of personalization and the fact that the best target for neuromodulation may vary among individuals owing to the very heterogeneous nature of MDD. In terms of deep brain stimulation strategies, symptoms may vary significantly over time, so continuous stimulation may have real limitations. there's a risk of counterproductive neural adaptation or other poorly understood effects that could be counterproductive. And it's the difficulty of maintaining effective continuous stimulation is sometimes complicated or exemplified by side effects involving sleep and other activation-oriented effects. Another key question is, how do you dose? MDD therapies typically take 4 to 8 weeks, from a medical pharmaceutical standpoint. So how do you deal with these challenges in the context of neuromodulation? Well, if you look at the growing understanding that we do have with respect to underlying neural circuitry based on resting state fMRI and other data, thanks to some really pioneering work by Helen Mayberg and others across the field, we're not starting from zero here. There is a growing number of stimulation targets that we can potentially work from. Of course, that represents a challenge with respect to identifying where to start with a clinical trial, but it does give us a framework, as is illustrated on the right-hand side there. Before the sensing era of neuromodulation came into reality in the last few years, there's been a wide array of previous clinical trials completed looking at the effects of neuromodulation for major depression with mixed results, but with a certain degree of signal in terms of there potentially being a there there. And some of the challenges that came to light there really had to do with the parameter of time. In terms of titrating doses and optimizing stimulation targets and stimulation conditions based on immediate effects, it's not always clear the relevancy of those immediate effects for longer-term improvement. And some of these challenges were exemplified in some of these pioneering trials. Here's another one. This is the well-known trial of a subclassal cingulate that was undertaken some years back now that was stopped at midway point due to a positive futility analysis. But I think there's a broad understanding that the structure here was suboptimal for assessing long-term effects of this approach. So in the meantime, thanks to the work of many groups, there have been emerging clues as to ways to potentially improve our approaches for personalized treatment for major depression and potentially other neuropsychiatric disorders, signals relating to target selection effectiveness based on network connectivity, in particular a commonality in some studies of confluence of major white matter tracts among responders to stimulation. And again, in some of these studies, positive response acutely in the intraoperative setting also seemed to correlate with longer-term effectiveness of neuromodulation. So in terms of personalizing therapy here, we have a number of things to focus on. We want to select the most promising sites for implantation, of course. We want to map major depression response to stimulation in an objective way, as systematically as possible. We want to select the best site for each individual from among options that are informed by side effect trade-offs. And all of this is only really makes sense for developing a sense-enabled, quote-unquote, closed-loop stimulation paradigm if immediate stimulation response is indeed results in therapeutic effect or is predictive of a positive therapeutic effect. So we've decided to take advantage of the potential for using brain sensing in real time to optimize and personalize neuromodulation for major depression. Here in this scenario neural signals are continually assayed. The sense neural signal is, compared to a reference signal in real time. If the difference between the threshold set is reached, the stimulation is triggered. And hopefully with this sort of approach, we're able to address one of the problems of constant stimulation or continuous stimulation relating to the intermittency of symptoms, triggering mania or other activation side effects when patients are not experiencing depression symptoms, and also the mitigating the hypothetical risk of adaptation. So again, this approach is sort of predicated on a couple of possibilities. One being that, as I said earlier, acute stimulation is immediately therapeutic, or at least indicative of a positive therapeutic effect. And in order for sense-enabled or sense-informed stimulation to really work, ideally you have a stable biomarker that reflects depression symptom severity consistently over time. So all of this informed our design of our Presidio study. This is a single-center safety and feasibility trial. It's a small trial aiming to recruit a total of 13 patients. The explicit hypothesis here is that stimulation can lead to immediate therapeutic effect. We did have evidence of this from our earlier DARPA-sponsored work on the Subnets project, working with epilepsy patients in the EMU. And our study objectives were multifold: to identify a personalized stimulation site that leads to improvement in depression severity, to identify a neurobiomarker of symptom severity and integrate that into an algorithm. In this case, we're using the NeuroPace RNS system as our sense-enabled device. And in stage 3 of the study, to demonstrate the feasibility of closed-loop therapy, demonstrate its safety in comparison to current DBS approaches, and hopefully to demonstrate the efficacy of so-called closed-loop DBS. So here's a study overview. As just mentioned, it has 3 stages with 3 corresponding objectives. The first stage is an inpatient monitoring and evaluation phase where there is a multi-site intracranial EEG implantation followed by 10 days of inpatient testing, observation, and discovery, after which intracranial leads are explanted. And there is an analysis assessing whether the patient has been found to substantively have benefited from at least some aspects of stimulation study during that 10-day discovery period. If they have, and it looks like there's a reason to believe they may benefit from a chronic study, they progress to stage 2. Following a baseline assessment, there follows a stimulation optimization study, as well as a biomarker verification study, again looking for those 2 ingredients for effective closed loop: having a robust, reliable biomarker that tracks with symptoms on the one hand, and a stimulation site that can reliably offer relief of symptoms. Provided that there is a suitably effective optimized approach that's identified in stage 2, the patient then progresses to stage 3, blinded crossover study. There are a couple of blinded crossover periods in stage 3, followed by long-term follow-up. And as mentioned, the primary outcome measure here is a change in MADRS score over 6-week periods. So here's just an overview of the study population. We're specifically enrolling severe treatment-resistant patients with the characteristics that are shown here. Obviously, this is an invasive trial, and the objective here is to identify patients who have not benefited under a number of more standard therapeutic regimens. In some cases, we are interested in patients for whom ECT has not offered sustained response or they have not been able to tolerate its side effects. But an indication of some improvement over ECT we see as a positive, just in terms of being able to, just in terms of indicating that there are intact networks that are able to respond. So here's a quick overview. There's a lot of information here. Recent paper that we published is cited in the lower right here. So for anyone who's interested in details for some of the findings that I'm just going to touch on here at a relatively high level, I encourage you to take a look at the paper for some details, and of course reach out to us with any follow-up questions. But on the left-hand side here, you can see just an illustration of the intracranial EEG monitoring setup. Again, this is for the 10-day discovery period, covering major regions correlated with the underlying circuitry that was illustrated in one of the earlier slides across the mesolimbic circuitry. And you can see in the flow chart on the right-hand side the combination of clinical mapping to assess the effectiveness of different stimulation sites over those regions on the one hand, and then again the second ingredient, identifying putative neural signals that may correlate with symptom biomarkers in the long run. And you can see, in terms of identifying stimulation sites, the basic approach is to assess symptom severity using various depression scales in a regular fashion, interspersed with multi-minute durations of stim or sham to which the patient is blinded. You can see some of the stimulation parameters noted there. And on the right-hand side, the approach is generally to take in-depth spectral recordings and use machine learning to identify biomarkers of high symptom state. The next step is really to test the viability of stim sensing candidate pairs with the NeuroPace RNS system. We have 2 leads to work with, which is not a lot, for contacts on each lead. So we need to be smart about where we ultimately decide to make the chronic implantation for our stage 2 study. So there are a number of different approaches that we've taken here. On the left-hand side at the bottom, you can see that includes network connectivity assessments across these networks, looking at structural connectivity to assess the extent to which a patient's particular network anatomy is correlating with the effects that we're seeing, and then assessing the feasibility of closed-loop control for any given combination of pairs of potential stimulation and sensing sites. So just as a quick overview of the stage 1 results from our first patient. On the left-hand side here, you can see the overall timeline that I've just summarized. That goes from surgery through stimulation, stimulation effect mapping, and biomarker discovery. And you can see some of the highlights here. The bottom line is that we were able to identify immediate and reproducible effects in some of our stimulation sites. In some of those instances, we saw dose-dependent symptom relief with stimulation. We definitely did observe state dependency of stimulation results, and we could talk about that in a discussion if others are interested in that. I think it's an important thing to consider from a practical standpoint for all of our trials. We saw sustained effects that were immediately therapeutic, so that was great, clicking many of the boxes we were looking for. And here is just kind of an overview of the biomarker discovery process that we undertook in a little bit more detail. You can see on the left-hand side, again, depression scales bounding either side of multi-minute at-rest spectral power recordings. In the middle there, you can see nice differentiation in visual analog scales for anxiety on the y-axis and depression on the x-axis, corresponding to HAM-D scores. And through the machine learning processes that I alluded to earlier, we identified right amygdala gamma signals as being most closely correlated in this patient with her symptoms. Furthermore, we were able to make some nice headway in identifying effective stimulation sites, as indicated here on VCVS. I won't go into the details there in the interest of time, but again, our recently published papers give some nice detailed accounts there. We also were able to identify dose-dependent mean evoked potentials in looking at connectivity through stimulation of the VCVS site, including strong evoked responses in amygdala, which is where we saw our biomarker. So this combination of findings really helped to support a plan for chronic implantation in right VCVS and right amygdala for this patient. So they progressed to stage 2 because we did see evidence of effective stimulation in stage 1, successfully implanted the NeuroPace device, and were able to replicate the clinical response in now this new chronically implanted situation, as shown in the middle panel there, looking to optimize the best effect among the VCVS contacts as shown there. And on the right-hand side, you can see that the biomarker that we had identified as a candidate in stage 1 was verified, and we were able to establish a close relationship between gamma power and amygdala in the contacts sensed by the chronically implanted device and symptom scales. We also had to do a little bit of optimization with respect to the burst duration for the VCVS stimulation, as shown on the left-hand side. We ultimately selected 6-second burst as optimizing effects reliably for both the HAM-D measure and the visual analog scale for depression measure. And then on the right-hand side is the summary over roughly 2 months, showing a normalized number of detections by the device. This, again, is detections of crossing the amygdala symptom biomarker threshold, shown in gray. And then on the lower violet chart, you can see the normalized symptom severity tracking down over time. Interestingly, what we found in most recent observations with this patient is that the number of her detections actually really started to go down. It happened to coincide with a COVID infection, and so among other things, all the other various considerations for a trial like this, one of the challenges is determining if decrease in the number of biomarker-triggered detections and an upcreep in symptoms, which is what we started to see, might be a temporary effect of a COVID infection, or whether it might represent a more natural progression of stimulation over time. At this point, over a year past the chronic implantation. So we'll stay tuned on that front. So this is just a highlight from some of the early effects of chronic stimulation with respect to symptom severity. You can see in the top figure on the right-hand side, pre and post scores for both the visual analog scale and the HAM-D before and after implementation of the closed-loop stimulation scheme for this patient. We limited the number of stimulations that she actually received per day and wound up turning down or turning off the opportunity for stimulation after 10 p.m. because it was affecting her sleep. But we did see an overall rapid improvement in her symptom severity and overall depression. And at this point, she's remained in remission for over 12 months, with the exception of the first instantiation of the stage 3 sham-controlled double-blind controlled trial. So once that is unblinded, we'll be able to say a little bit more in terms of interpretation of that. So before we shift to discussion, I just wanted to make a couple of comments about emerging observations from our studies. First is, we consistently see evidence of state-dependent effects of stimulation, in patients who otherwise are showing symptom improvement in response to stimulation. That effect can very much be influenced by the state at the time of stimulation. So, for example, if the patient is symptomatic but in an activated state and they receive stimulation at a given site, say orbital frontal cortex, that may improve their symptoms. But if they're symptomatic but in a low activation or low arousal state, stimulate the same site with the same parameters, you might get a worsening of symptoms. So there's a huge parameter space that we have to explore here, and symptom state and time are probably two of the most challenging ones. We've also observed effects of setting, in particular in clinic settings during our stage 1 monitoring phase. This, again, is inpatient. As a result of that, our study teams have begun to take a little bit more conservative approach in assessing the effects of stimulation, looking over longer periods with the same set of parameters, especially if there's an indication that that parameter set might be effective, just to verify that the effect is robust over a period of time during which the study team has observed that a given patient tends to have fluctuating symptoms and mood as a result of the study team being there. So things get a little bit complicated with neuropsychiatric disorders for this reason, and I just want to highlight it as something that I think we're going to have to be considerate of going forward. Of course, this also relates to patient heterogeneity and the emerging understanding that our team has that assessing severity state is a multi-pronged approach, ideally, but also needs to be personalized to a given individual's temperament and symptom presentation. And in some cases, for patients who do not readily verbalize their internal state or would prefer not to or find it anxiety-producing, we've sometimes had a blinded observer in the room to take note of their outward behaviors that may be indicative of an internal symptom state. So, the main conclusions from our trial so far are listed here. I've emphasized our experience with our first patient because that patient is the furthest along. We have another couple of patients who are now in stage 2, so they've both progressed through that stage 1 discovery stage and are now in the biomarker verification, validation, and stimulation optimization stage. We did have a fourth patient who did not receive sufficient benefit of stimulation in the stage 1 trial to progress to stage 2. But in general, what we're seeing so far is consistent with the idea that for at least some patients, sensing informed stimulation through a closed-loop paradigm may be quite effective for relieving severe depression symptoms. And as I mentioned earlier, we look forward to significantly expanding on this N of 1 to see what more we can discover about tackling the heterogeneity of symptoms and experiences with this patient population. So we look forward to keeping you updated on that. Just want to acknowledge again the team that's behind the work and continues to work on it. It's an expanding team, but it is led by a combination of really wonderful clinician scientists, Catherine Skangos, who's a psychiatrist and a neurophysiology specialist, Edward Chang, who's a neurosurgeon, psychiatrist Andrew Crystal, and our other collaborating neurosurgeon, Phil Starr. Very happy to answer any questions. Thank you so much.
There we go. So awesome. Thank you, Heather. We do have a bit of time for questions in between speakers, and if you have one, raise your hand, and the folks with the mic will come to you. I will take the chair's prerogative to ask one. How are you folks, or maybe you aren't at this point yet, how are you thinking about how we do scaling, dissemination, and replication? Because one of the things I think this slide you put up last really highlights is the amazing confluence of knowledge and skill that needs to go into each individual patient in an approach like this. And somehow we've got to be able to do that and replicate it in multi-center trials.
I think it's really the million-dollar question, Alik. You've hit the nail on the head. And
that's it. That's cheap.
No. We think about after that introduction, I have to be very flattering to you too. But it's wonderful. It's obviously at the center of work in this field because we're trying to tackle so many questions at once. It's requiring very in-depth, sophisticated trials with highly specialized trial teams. These have to be some of the most complex clinical trials that have been done in a while. But I think that there are a number of ways of looking at it. I'll just speak for myself. I can't speak for the ways that everybody on the team is currently thinking. But I really see this kind of work as necessary and specialized and hopefully leading to much more effective patient stratification and diagnostic approaches so that we can bring a much more streamlined approach to therapy in a much more informed way to patients who are exhibiting combinations of symptoms, symptom dynamics, circuitry, connectivity, and response to previous therapies to classify their disease and their personalized therapeutic approach in a much more informed way than we are now. Otherwise, it's not scalable, I think is the answer.
Well, even so, the fact that you were pushing this envelope, I think I saw Dr. Lemos with a question.
I was wondering right here.
Oh, hi.
You can stand up and maybe introduce yourself.
Thanks, Alex. Julia Lemos, University of Minnesota. I'm wondering if the stimulation is being paired or if there's a plan to pair the stimulation with cognitive behavioral therapy. I feel like I remember in the early days of DBS and depression, the idea was that it increased the efficacy or receptiveness of cognitive behavioral therapy. So I'm wondering if that would maybe increase the efficacy of the stimulation or just make it less variable, like stabilize it?
Yeah, it's a wonderful question. You're absolutely right. That's been an idea that's been around for a while, and I still think it's a really exciting one. There are a number of different reasons, not mutually exclusive, why this kind of effect might be this kind of neuromodulation might be effective for a given patient. Some of those mechanisms may relate to neuroplasticity, and that notion definitely feeds into the idea of a combination of CBT and neuromodulation being really effective for at least some patients. We definitely have considered that actively, especially in that DARPA-sponsored program that I mentioned earlier. That was actually a key thing that we were aiming to incorporate, and it's one of the reasons why we worked really hard on identifying sort of multi-pronged symptom assessment measures, because it's impossible to really make headway with a multimodal therapeutic approach if you don't have confidence in your symptom measures. So I think at this stage, what we're aiming to do is focus on looking for strong, robust signals for the effectiveness of stim-based neuromodulation. And as soon as we have an opportunity to deliver that in a focused and informed way, where we have a reasonable level of confidence that it's going to be effective, at least up into a certain point, then when we layer in CBT, it'll be a lot more interpretable. But it's definitely out there in the future. Hopefully not too far in the future.
We've got time for at least one more. I think I see a hand up here.
Hi, nice talk. Very impressive work. I had two related questions. One is, sorry, I missed that. Are you recording and or stimulating in both VCVS and amygdala, or is it just one or the other? And then do you know exactly where you are in the amygdala? And what's your prediction about what's happening? Are you interfering with cellular physiology or fibers of passage, or what exactly is going on? Are you activating or inhibiting? What's happening in the physiology?
Now I wish we didn't have quite as much time for questions. No, those are wonderful questions, of course. With the setup with this first patient, we're stimulating a VCVS and sensing in amygdala. And, just as a side note on that topic, when we're in the stage 2 with other patients where we have 2 regions that are implanted, that might not necessarily be the case. We may be evaluating stimulation effects in both regions across various contact pairs in those 2 regions, as well as evaluating biomarker detection potential on both leads. So that stage 2 optimization phase is really important for sort of fully exploiting the potential of, in this case, the 2 regions that you've implanted. I can't remark specifically on where the contacts are in amygdala. I apologize, but maybe if we meet up later, we can take a close look and I'll let you know. And what is the basis for the effect? Not sure, but I think, not sure, I don't know. But I think the fact that there was demonstrated strong connectivity between effective VCVS stimulation sites and the amygdala demonstrates that there's a functionally connected circuit there that is potentially forming the basis for at least some of these effects. Whether it's a positive a positive signal effect or scrambling white noise effect of maladaptive circuitry, impossible to know right now, but it's a really intriguing area to think about and think about how to set up future experiments to address.
Thank you.
Yeah.
Thank you, Dr. Dawes. If we could give her a round of applause again, we can head on to our next speaker, who is going to have to be virtually present, so give us a moment. So our second speaker, owing to some complex logistical and virus-related difficulties, is going to come to us virtually, but it's still my pleasure to introduce Dr. Kelly Bijanki from, as she says right there, from Baylor College of Medicine, who, in addition to being an awesome neural engineer, and literally she and Dr. Dawes' team are the 2 people in the world who've taken this kind of very precision medicine approach to treatment of depression. So you walk out of here, you will have heard everything that is known on the topic. Dr. Bijanki also completely belongs in the Central Time Zone. She actually did her graduate work at Iowa, took a sojourn at Emory on the East Coast to learn a ton of things about neurophysiology and deep brain stimulation, and then came back to Texas. So she's going to talk to us about some amazing work they're doing on different ways to optimize stimulation parameters for depression. And take it away, Kelly.
Wow, well, thank you, Alik. That was a very generous introduction, and I want to start first off with just a huge thank you to you guys, the organizing committee, the co-chairs, for putting this together and for the invitation to speak today, and also just to express what an honor it is to present after Dr. Dawes. I've been a long-time admirer of her work, and it's been really a wonderful way that she set up sort of the clinical setting in the background with the deep brain stimulation studies. So I'm going to jump into a little bit more of like the detail and data analysis that we've undertaken here at Baylor. So in this presentation, I have the privilege of sharing with you a set of experiments that try to leverage the insights of stereotactic EEG in order to inform deep brain stimulation therapy for treatment-resistant depression. Very, very similar to what you would say to describe Dr. Dawes' approach as well. So in the first part of this talk, I'm going to talk a little bit about our design and philosophy of the study. The second part, we'll talk about what we do during the intracranial monitoring period and our approach to characterizing treatment-resistant depression in terms of the network activity. And then in the third part, we'll discuss our efforts about trying to map the depression circuitry using a new technique that we've recently published, which involves a multimodal fusion of preoperative neuroimaging and intracranial electrophysiology. Just to start, I have no financial disclosures. I do have intellectual property related to the targeted stimulation of the cingulin bundle, which we won't be getting into here. So as Dr. Dawes set up very clearly in her presentation as well, there are several brain targets undergoing active investigation for treatment-resistant depression. They're indicated here. Our study focuses on the ventral capsule-ventral striatum and the subcallosal cingulate target. And we're investigating these targets simultaneously with the SEEG electrodes. The SEEG approach is borrowed from the epilepsy model. So this is a routine diagnostic practice in the surgical treatment of epilepsy. When I talk about this depression study, often the question is, my goodness, that's very invasive. You're putting all these electrodes in the patient's brain, and those electrodes that you're putting in to characterize the network are not necessarily intended to be curative. So how can you justify that? And part of that answer is that we have been doing this for a very similar purpose in epilepsy for a very long time, decades at least. And the purpose in epilepsy is to implant the depth electrodes in the brain, record from them over a period of time, monitor during a hospital stay, and we use that information to provide guidance on the neural underpinnings of the disorder and to guide the next steps to treatment. So we're doing this in epilepsy. Epilepsy is an enormous contributor of disability and difficulty in the world, of course, but our argument is this can also be said, and perhaps even more so, about neuropsychiatric disorders. And so we're taking this approach in treatment-resistant depression. So the structure of our study, so the parent study is a UH3 funded by the National Institutes of Neurological Disease and Stroke. And the PIs of the clinical trial are Samir Sheth, Nader Paradian, and Wayne Goodman. The two main sites for data collection are at Baylor College of Medicine in Houston and University of Texas Southwestern in Dallas. I have the honor and privilege of working with this group to provide guidance in terms of imaging and neuroscience, and my lab was recently awarded an R01 for sort of an add-on study to this, where we're able to collect additional data in the EMU phase in the treatment-resistant depression study, and then collect corresponding data from epilepsy patients in the same EMU at Baylor, so that we can sample across a wide range of depressive symptoms up to and including treatment resistance. So just talking a little bit about the philosophy of the UH3 study, and very similar, I think even this figure is repeated between our two presentations, but we too believe that network disorders demand network-based therapies, and that the use of an epilepsy-style intracranial recording provides a unique perspective into network activity and the effects of stimulation. We think that the individualization of imaging and electrophysiological analyses will hopefully be able to drive improvement in patient outcomes. So I like to show this little video clip to demonstrate kind of the structure of the study and the patient side experience a little bit more. The study enrolls patients with treatment-resistant depression. These patients have failed to respond to a variety of prior adequate therapies. I believe our list is almost identical to the inclusion-exclusion criteria that Dr. Dawes showed a few minutes ago, so I won't get too far into that here. But we believe that the underlying brain state in these cases may include electrophysiological abnormalities, which we first try to quantify through intracranial recordings during depression-relevant cognitive tasks and at rest. Then we apply stimulation to the DBS electrodes to characterize the nature of the brain's response to stimulation across a variety of stimulation parameter combinations, and the change of the depressive state signals in response, from the neural tissue. So after 10 days study in the EMU, the SEEG electrodes come out. Implantable pulse generators are placed permanently subclavicularly, and the patient begins a chronic outpatient DBS treatment optimization phase. So in this study, there are two main goals. The first is to characterize the pathophysiological state underlying treatment-resistant depression, and the second is to use a data-driven approach in the development of stimulation programming parameters that are individualized to these patients based on their own brain recordings. Electrodes are generally, the way that the study was designed, the electrodes were targeted to sort of general areas of interest for depression. The blue are the temporary electrodes, the red are the permanent electrodes. They're all implanted in the same initial surgery. The SEEG electrodes, generally the idea was to cover dorsolateral prefrontal cortices, ventromedial and ventrolateral prefrontal cortices, medial and lateral OFC, and then amygdala and anterior cingulate. Over time, though, we have found, and as alluded to by Dr. Dawes, that there's a lot of variation in the brain anatomy and the idealized targeting of these regions. They're also really big regions, so how do you decide which portion of the anterior cingulate you should put the SEEG electrode in? So we have an ongoing and very fruitful collaboration with Dr. Cameron McIntyre, now at Duke, and he and we then use patient-specific probabilistic tractography to define the implant targets for the subclosal cingulate and the VCVS, like the DBS targets, based on prior published work, including the beautiful diffusion tensor imaging and targeting studies done by Dr. McIntyre, Dr. Choi, and Dr. Mayberg at Emory. For the SCC, we're targeting the confluence of major fiber systems, so forceps minor, cingulum bundle, in the uncinate fasciculus. And then we use a similar but new approach that we've developed during this process and in collaboration actually with Dr. Sarah Heilbronner, who you'll be hearing from in just a minute, to target the ventral capsule and ventral striatum. The approach that we've taken here is to maximize engagement to the fibers of the anterior limb that innervate orbitofrontal and ventromedial prefrontal cortices. So these methods have been recently published. The SCC method is published in Solaki et al. 2021, and the VCVS method is described in Banks et al. 2022. Dr. McIntyre's lab provides biophysical modeling of the volume of tissue activated in the planned positions of the SCC and VCVS electrodes. Then we get into the Microsoft HoloLens device, which provides a holographic surgical planning environment in which, this volume, this brain, isn't actually there, of course. It's just being projected on each person's HoloLens device. But we're able to step through the surgery together in real time and see only the pieces of the brain that we think are relevant for the decision being made about the patient's targeting. So Dr. McIntyre and Angela Naker, an engineer in his lab, have created a way of moving basically the patient-specific preoperative neuroimaging into this environment. So we're actually planning in the patient's brain, in the patient's tractography, and with patient-specific then biophysical models of how much of the fiber system surrounding the DBS implant targets is going to be activated and which fibers are going to where. So once we can see what we're going to stimulate and where those fibers go, then we place the SEEG electrodes at the terminations of those fiber bundles in each patient. We did this the first time. Our first patient actually was in the EMU in February of 2020, so things changed even over the course of his time in the hospital. By the end of that time, everyone was being temperature screened and masked and all that. So for our second patient, actually, Dr. McIntyre and Dr. Naker solved this location problem and made it so that we could actually be in different cities across the country in the same virtual environment, holographic environment, to do the surgical planning and do the same patient-specific implant trajectory planning remotely. So still through the HoloLens device, we were all able to interact with the patient's anatomy to do the planning. Okay, so just a little more about the study design for the parent study. I think this is somewhat similar to what Dr. Dawes described with some differences. Where we are now, we've just completed our 4th participant. She actually just left the EMU a few weeks ago, and we're planning to do 6 patients at Baylor and then the following 6 patients at UT Southwestern. The patients do their EMU phase, then the open label optimization phase, and then move into a double-blinded randomized discontinuation. When we do this, we randomize which of the 2 targets is withdrawn. Then we do a stepwise withdrawal and measure the patient's depression responses as we're withdrawing first one, and then if that doesn't change the depression scores, then we withdraw the second target. So the findings from the first patient are indicated here. So these are the clinical scale scores that we measured from pre-op. In yellow, you can see the EMU phase, a drop in the ratings after the EMU phase as the patient steps through the open label optimization phase. Then the patient entered the double-blinded randomized discontinuation, in which the SCC was discontinued with the VCVS still continuing. And with the withdrawal of the SCC target by itself, the patient actually met escape criteria for the discontinuation, exited the formal phase of the study, and is now just in open label DBS therapy. We reinstantiated the SCC stimulation, and the patient continues to be classified as in remission. These findings were recently published in Biological Psychiatry, and if you have any questions about the further details about how that patient has done, please let me know at the end. So that's been kind of the overview of the clinical trial as a whole. Now I'm going to change gears a little bit to focus on the intracranial monitoring phase. So after implantation, our patients are moved into the EMU, and here you can see kind of a sketch of how the time goes. In blue is plotted the instantaneous measure of the patient's depression. This is using the computerized adaptive test for depressive symptoms, so it administers different questions each time that we ask the patient to complete the task. In the early days in the EMU, the patient is, trying to get to feeling better after their surgery. They do basic sort of recording tasks and things. We start with ones that are not terribly cognitively taxing, and then move into a range of behavioral tasks relevant to their depression. Before we begin an exploration of stimulation parameter space, we start with short stimulation durations at single contacts and individual leads, slowly working up toward longer and multi-lead stimulation paradigms on days like 7 and 8, and culminating with repeats of our cognitive tasks during task-specific individualized stimulation parameter application. So we're trying to evaluate our capacity to differentially modulate different portions of the network corresponding with cognitive control, reward sensitivity, and negative affect. So in the next few slides, I'll show some examples of our method for decoding the neural state corresponding with the affective neuroscience tasks and developing targeted approaches to stimulation parameter recommendation. But first I want to just step through a little bit of the detail on our stimulation experiments. So as I mentioned, we start with the the very lowest level stimulation. So we do single pulse stimulation at each of our current directions of interest. Our DBS leads are the Boston Scientific Cartesia lead system, so they're segmented steerable leads. That means the middle two contacts are actually segmented. So if you looked at it rotated, you would see that there are three contacts along kind of the three parts of the cylinder of the leads for these middle positions. And so our sampling in terms of the stimulation current direction includes stimulation to analogous to like a Medtronic 3389 lead, just like a regular contact. The deepest contact, middle, upper middle, and top. Then we also do stacked stimulation, monopolar cathodic, to either the anterior facing stack, the medial facing stack, or the lateral facing stack in each of the four then lead positions, left and right, BCBS and SCC. So we do single pulse stimulation to try to understand the physical connections and effective connections of the network. We do 1 second stimulation, stepping across sort of a rectangular sampling of the frequency, amplitude, pulse width, and current direction parameter space. This gets to be a very long experiment. It takes 16 hours in total. We break it up into small blocks, but that's why on the timeline it represents 3 days to get through all of this with the patient. The patient during the 1 second stimulation, it's purely an electrophysiology experiment, so they're not asked to rate how they feel after every one of these combinations or anything like that. Then we move into something sort of analogous to the outpatient programming phase, where our study psychiatrists, Dr. Sanjay Matthew and Dr. Wayne Goodman, sit with the patient in the EMU as we step through stimulation at increasing durations, where we really are then looking for that acute behavioral effect. And this is in the hopes of being able to identify something close to what would be identified in the programming phase, so that then we can get the intracranial recordings corresponding with that to see whether the neural pattern of response that you get with the behaviorally defined, like classic programming approach, looks similar or different to the neural response to stimulation parameters that we've generated and optimized in other ways, using the data, for example, the electrophysiology data. So we've developed a variety of tools. This is the RAVE package for visualization of intracranial studies. So this is the work of Raisa Matura, who's a research study coordinator in our group. And you can see that we've developed ways of projecting the power of particular frequency bands onto each of our recording position electrodes, the SEEGs, and then we can look at the responses across the network following stimulation to a particular DBS contact. So you can see that this was stepping through stimulation first to left SCC, which engages a pretty broad portion of the network, but centered more on the left. Now she switched it to centered on the right SCC. And then when we move to the VCDF stimulation, we get a more narrow kind of pattern of contacts that are picking up this effect. Okay. Now I want to talk a little bit about one of the cognitive tasks that we use with the participants. This is called the affective bias task, in which patients rate the intensity and the valence of emotional facial expressions that we present to them. So the patients evaluate a series of faces ranging from very sad to neutral to very happy. And we can use this task in two ways. The first way is just as a probe of activation in general of emotion-relevant brain areas in people with depression. So the first way we're doing this is looking across the theta, alpha, and beta frequency ranges to see changes in power and differences in neural response to one or the other type of faces. So this all goes toward our global goal of characterizing the network activity in treatment-resistant depression. So here we can see, following the onset of a happy face that the patient is evaluating when we record from, this is actually a contact right here. So that's approximately ventrolateral or lateral orbitofrontal cortex. We see an increase in the theta and alpha and maybe a little bit of the beta range following the onset of that happy face that the patient is looking at. By comparison, when that patient is looking at a sad face, we see a reduction in the theta and alpha range during the evaluation of that face. So this is, these spectrograms are for a single contact, but then we can decompose that information to project it onto all of our electrodes. And so here you can see then plotted which contacts show in warmer colors greater response to happy, greater than sad faces when we're measuring from the theta range or the alpha range or the beta range. And so we see generally in treatment-resistant depression that the brain tends to be more responsive to happy faces than sad faces, where you define more responsive as greater power, which is arguable in any case. Then we can use the bias task as well to see how that network activity has changed over the course of the EMU stay or over different periods of interest. So as we were just looking at in the alpha and the theta bands, we were seeing increased activity in these contacts in the evaluation of happy faces prior to the patient receiving any stimulation. By the time we get to EMU day 9, we see that the network has perhaps shifted, that the contacts that are responding are generally different, and that the contacts are perhaps more responsive to sad faces than to happy faces. So we're starting to think into how to quantify this network state change as a potential indicator of this corresponded with the patient also becoming less depressed. So is this one way of quantifying network shift that corresponds with an antidepressant effect? My lab is further interested in cross comparisons. We've got these intracranial electrodes in epilepsy patients who represent a range of depressive disorders. And so then during the evaluation of those emotional faces, we can see what effects are conserved and not conserved across these patient populations. So recording from the right medial sort of orbitofrontal cortex across these 3 participant groups, we're able to see then kind of what's the same and what's different. In a depressed brain, we see in response to sad faces. In patients with epilepsy and depression, we see this happy face increase thing. This is conserved kind of across epilepsy with depression, epilepsy without depression. But down here, in the response to the sad faces, we see in depression, or in treatment-resistant depression, we see reduced activity in response to sad faces. In the epilepsy with depression, we see something kind of a mixed response. And then in epilepsy without depression, we actually see the opposite direction of the effect. So this is very preliminary. The study that supports this was very recently funded, and the analysis here anyway is of single patients. So this very certainly warrants greater data collection and group level analysis to convince ourselves of what we're seeing here. But all of these efforts are toward the solution of this complex problem, which was also articulated by Dr. Dawes earlier, but that we have nearly infinite parameter space when you consider all the levels of frequency and pulse width and amplitude and current direction and multiple leads and different targets of the brain that we could use to treat something like treatment-resistant depression. And right now, we don't have a good time component that relates between the stimulation we're able to administer and then any measure of behavior, the time is desynchronized from each other. The changes in behavior typically are observed on the order of weeks, where we can step through different stimulation parameters in seconds. So how do we cover enough stimulation parameter space and make sure that it's mapped onto the behavior in an accurate way? And so we think that characterization of the network state, so the stim-off recording tasks that we do, relating the network state to behavior, is one piece of this, defining the brain state that corresponds with the behavior we want to see and the behavior we don't want to see. And then also building out the relationship between different input parameters and that network state, so that then we can try to map between these to sort of to back propagate and try to reverse engineer the relationship between input parameters and behavior. So one way that we've tried to do this, we call this a template matching approach. It's sort of a simplistic idea, so I'll just tell it to you. It's that we're defining an ideal brain state and then searching the brain responses to stimulation across all the stimulation we've done to see which one most closely recapitulates the desired state as we've defined it. So there are a lot of assumptions in there about what the desired state, how we establish the validity of the desired state, how many stimulation parameters we're able to sample across and then search from, but it's at least a first pass. So we characterize the power for each electrode and condition, and we're expecting anyway to see that there are ongoing sort of baseline activity features that we see in the neural recordings, that following stimulation in some contact we see, for example, a reduction in an ongoing endogenous oscillation, and that may be then more in accordance with, for example, in the yellow, some desired state activity. So then we build correlation matrices to relate the power by condition against frequency, so theta, alpha, and beta. Then we iteratively fit a generalized linear model to optimize the stimulation parameters to evoke our desired brain state. This is the work of Brian Metzger, a postdoc in my lab. So I'm almost out of time here. I'm going to jump forward a little bit. So the last portion of the talk, I wanted to talk a little bit about our single pulse evoked potential study. So this is trying to align between the anticipated relationships that we thought we were going to see between the biophysical models of stimulation fields and then the models of the diffusion tensor imaging and the tractography assumptions that all go into that. That then guided the placement of the SEEG electrodes. We can quantify how likely we think a particular stimulation configuration is to engage a particular contact that we're recording from, and then we can test that prediction by doing a single pulse on that configuration of contacts on the electrode and measure whether we get single pulse evoked potentials measured at that recording position. And so I'll give you this example of stimulation to the SCC recording from the medial orbitofrontal cortex. You can see the predicted connectivity from the DTI is that it would be pretty strong, and then the corresponding evoked potentials measured from the OFC when we stimulate there are expected to align with each other. And when we quantify the number of streamline predictions, where warmer colors indicate a greater number of streamlines, that's my timer, predicted between the SFM and the recording positions, then we can see how aligned they are with the observation of evoked responses in the orbitofrontal cortex, where we saw in blue here, each one is a contact in the orbitofrontal cortex on the right and the left, that actually did trigger and evoke potential in the way that we would expect it. If you're curious about this study, I'm going to cut off here for time, but our paper is recently out in brain stimulation, and I'm happy to answer questions starting right after the most important part of the talk, which is to thank my lab, to thank the amazing group at the Baylor Intracranial Neuromodulation Group, Samir Sheth, Wayne Goodman, the whole group across psychiatry, neurology, neuroimaging, radiology, postdocs, grad students that go into this, the grant support that we've been fortunate to receive, the other PIs on the UH3 project, and my key external collaborators. And I'll take any questions, and thank you for your attention.
Awesome. Thank you, Kelly. And I think we probably have time for exactly one question, but we've got one in the audience.
I have
there's one, and you can type the answer one in the chat.
Now, if anyone is talking.
Going once.
Okay.
All right.
Let's see. We selected the Boston Scientific leads from.
I'll ask you one quick one. Well, maybe it's quick. Maybe
sorry, because at the time that was the only segmented variable.
So, the one question I would ask you very quickly, I think you mentioned something that Heather also mentioned, which is that you had a sense that when you were collecting information from the patient, that was actually changing the patient's response, that they were fatiguing, that they were getting confused. Can you comment on how you are thinking about getting around that?
So we're pretty careful about how many questions we ask the patient and how those questions are. So we put a lot of time into electrophysiology only. So a lot of the stimulation we do, we're not asking the patient to continuously reflect on their emotional state. We think that would be too taxing for them to maintain, for example, in the one something experiment for 16 hours. But we do, I think, like part of the secret approach or whatever is the relationship between the psychiatrist and the patient. So like at first, every time they're asked how they're feeling, it's like, they have to evaluate every dimension of their experience. It takes a really long time. And then they sort of develop this shorthand with the psychiatrist and the psychiatrist with them. So they can say, oh, this part of it isn't changed, this part is not, and this part it feels a lot better or whatever. And they generally get it down to just like articulating the change rather than full description. I think that is a lot less taxing to the.
Awesome. Thank you for joining us, at least virtually, and hopefully you'll be around on the Zoom in case there are further questions as we transition speakers. So we look forward to seeing you up here at a more favorable future date. Thank you, Kelly.
Thank you.
And I think that in many ways, the nice thing about the order of these speakers is that the figures that Dr. Bijanki was showing about, hey, we have to get the placement exactly right, really segue into our last talk from our own Dr. Sarah Heilbronner, who is really one of the leading neuroanatomists of specifically the pathways that we go after with deep brain stimulation. So Sarah originally did her PhD at Duke, then spent many years at the University of Rochester, where she really became one of the foremost experts on the structure of the basal ganglia and the pathways that run through them. And then we were lucky enough to land her here. Many of you have heard me tell the story that one of the things that made me certain I needed to move my lab here was when the chair of neuroscience told me that they'd recruited Sarah, and I'd been wanting to collaborate with her for years. So how are we looking? Is the AV still? Can we get some help? Maybe Ben could do them by charades or shadow puppets. I bet you could do some pretty good anterior limb of the internal capsule. Oh, there we go. Yes. All right, so Sarah is going to take us through a tour of how we are now really refining these wiring diagrams to the single patient level. Let's welcome her.
Thank you so much for that introduction, Alik. Sorry for the technical difficulties there. Right, so I'm interested in the brain's wiring diagram. So I'm going to take a step back and be a little bit less clinical during this talk, but hopefully I'll wind up connecting up with both what Heather talked about, and what Kelly talked about. So neurons are specialized for communication, and one of the key things that I think we need to know about the brain is which neurons are able to communicate information with each other, and that's what I call the wiring diagram. And I have just two topics I'm going to cover, so not terribly much. One, how should we build a wiring diagram of the brain? And number two, why should we build a wiring diagram of the brain? So let's jump in with how. First of all, what do I mean by wiring diagram? And or to use a term I'll use actually more often during this talk, connectivity. Well, that term, connectivity or wiring diagram, that gets used in a number of ways, and the one thing they all have in common is that they produce stunning pictures, right? But in this case, I'm really interested in anatomical connectivity. And you already heard some about functional connectivity, about correlated activity patterns, and that can be inferred from fMRI or electrophysiology. It can be monosynaptic, polysynaptic. Let's set that aside for a moment. I'm interested in anatomical connectivity, in direct neuronal monosynaptic connectivity, the kind that you can only analyze with track tracing or other types of histological and microscopy techniques. There's another term here that you've heard already multiple times called structural connectivity. And in an ideal world, structural connectivity as measured through diffusion tractography is a perfect match with anatomical connectivity. In the perfect world, it's a perfect match. And that's because the goal of diffusion tractography is to use a non-invasive MRI measure to figure out anatomical connectivity. Now, unfortunately, we don't live in a perfect world. It's less than 100% match. This is a paper from 2014 showing within species, connectivity as measured through tractography versus track tracing. So anatomical connectivity versus structural connectivity. And you can see that while there's a positive, significant relationship, it's not all that strong. So certainly anatomical connectivity can't be perfectly or even super well reconstructed with structural connectivity or diffusion tractography. That paper was from 2014, and that's 8 years ago now, which is terrifying for other aging-related reasons. But the methods have improved in diffusion tractography, and that number has gone up. But there seems to be sort of an upper bound to where it is. And so improving diffusion tractography methods is a really important goal for trying to uncover the wiring diagram of the human brain. Now, you might be sitting there thinking, if you're not a neuroscientist or this isn't your field, why not just use the accurate thing, track tracing, in the human brain? And unfortunately, it requires an intracranial surgery and a time-sacrifice perfusion and brain extraction. And no institutional review board is going to let me do that. That's probably for the best. All right, so I think that in order to uncover the wiring diagram of the human brain, we need a multimodal cross-species approach. And what this looks like, I've been thinking through a lot, particularly with these three collaborators. This collaboration started over Zoom during the pandemic and just involved a lot of arguing and gesticulating. That's my major memory of this collaboration. And in the end, what we published was a huge treatise that came out recently in Cerebral Cortex, and I hope you'll all take a look. But essentially, what we tried to distill down was a few different cases, and what all of these depend on, there we go. What all of these depend on is there needs to be a bridge between non-human animals and humans, such that, in this case, we're going to use the monkey, and I'll come back to that later, but between monkey track tracing and human diffusion tractography. And the bridge between those is monkey diffusion tractography. And I'm going to walk you through why. So let's say that there's a tract or connection, and you see that connection in human diffusion tractography, and you see it in monkey tract tracing. Great. Life is amazing. Diffusion tractography, structural connectivity is doing what anatomical connectivity is doing. Done. No notes. Close the book. Unfortunately, that's not, like I said, always what we see. Instead, it's really quite common to see, for example, a connection in human diffusion tractography that is not seen in monkey tract tracing. Now, you could come to me and say, Sarah, your monkey tract tracing is all well and good, but humans are not monkeys. None of them are giving neuroscience talks today. And so presumably there are some connections that are present in humans that are not present in monkeys. How do you know this is not just a species difference? And that's whether we think it's a species difference or whether we think it's an error in diffusion tractography will depend on what happens with the monkey diffusion tractography. So if the monkey diffusion tractography finds that connection, we can infer that it's a false positive, right? Because the monkey tract tracing should perfectly match the monkey diffusion tractography, and we can know that the diffusion tractography is making an error in that case that's then being propagated to the human. Whereas if the monkey diffusion tractography does not find that connection, well, maybe that's a true potential species difference. All right, so making advances in diffusion tractography requires us to think about something that we traditionally have not given a ton of thought to. And nowhere is this more obvious than for someone like me who is a neuroanatomist interested in tract tracing. Going back decades, looking at old papers and seeing that people did this really beautiful tract tracing work, but the white matter was just not indicated. The trajectory of the axons was not taken into account. And so now we need to care about white matter. And so the details of putting these two ideas together, the organization of white matter and the diffusion tractography results, matters so much because diffusion tractography, I'm sure many of you are aware, relies upon the organization of white matter to make inferences about structural connectivity. So essentially the algorithms say, okay, which way is the white matter pointing at each point in the brain? And so once you know the underlying white matter organization, then you can improve your diffusion tractography algorithms. So I'm going to walk you through some specific examples of where these come together. And what I'm going to use here is the anterior limb of the internal capsule. Many of you care about the anterior limb of the internal capsule, including the previous two speakers. I want to be clear that although there's some difference in exact location, this is also overlapping with the BCDS target that people are talking about. All right, so this is a target that's extremely relevant for neuromodulation for psychiatric disorders. And what I've got over on the left-hand side here is the monkey tract tracing result. On the right is a typical result from human tractography, and in the middle, the monkey tractography and the appropriate inferences. So in this case, this is a very, very typical false positive result. The prefrontal cortex does not project in monkey tract tracing to the contralateral anterior limb of the internal capsule. That's just true. We just see it over thousands and thousands of injections. But in the human tractography, we often see streamlines or tracts going to the contralateral anterior limb of the internal capsule. Okay, is it possible that the human is different, or is this an error in diffusion tractography? Well, when we look in monkey diffusion tractography, we see that same pattern. And so we can infer that this is just a false positive. Other things go really well. Not everything is doom and gloom. The dorsal ventral position in the prefrontal cortex is reflected in the dorsal ventral position in the anterior limb of the internal capsule. That's part of what makes, that's part of what lets people doing DBS in the internal capsule change prefrontal cortical activity. And so you can see the blue is on top of the green, is on top of the red here with the monkey tract tracing. That's true in the monkey and the human tractography, and that looks really good. By contrast, you can get more than just a false positive or a false negative. You can get sort of a mix-up in topography. So the medial lateral origin of fibers in the prefrontal cortex gets reflected in a dorsal ventral gradient in the resulting fibers in the internal capsule. The details of that are not particularly important, but the point is that both human tractography and monkey tractography seem to struggle to reproduce that, and so we can be fairly certain that these results are not highly accurate and should not be used to sort of guide DBS electrode placement. All right, so along with improvements in the way that one of the ways that we can improve diffusion tractography is by improving data collection. And so here I'll just advertise we have the highest field large bore scanner in the world, which is a 10.5 Tesla, which is large enough to accommodate a human. And so humans as well as rhesus macaques are able to go in there, and we've recently published a paper on resting state fMRI, and coming out is the 10.5 Tesla non-human primate diffusion MRI as well. So I hope you'll keep an eye out for that. But in addition to problems of data collection, we can also improve just our thought processes about white matter and white matter organization. And I want to highlight a set of problems that, again, we covered in that recent cerebral cortex paper. So if I were to ask all of you, is this the corpus callosum? Probably a lot of you would look at it and be like, yeah, sure, that's the corpus callosum. What about this? Is one of those more the corpus callosum than something else? It gets trickier. The corpus callosum, maybe you're like, well, that's just semantics. That's not a very interesting problem. It gets trickier when you think about bundles that seem to, that are very, very difficult to define. So is this the cingulum bundle? I consider this the cingulum bundle in the monkey, and similar in the human. What you're seeing here is a set of fibers that is very much present in the same location as the cingulum bundle. But the cingulum bundle we think of as being a rostrocaudally organized set of fibers that connects the frontal, parietal, and temporal lobes. What you've got here is fibers crossing through the cingulate cortex to reach, say, the striatum, other cortical targets, other subcortical targets. Everything that is in the cingulate cortex needs to pass over the cingulum bundle here in order to make it out of the cingulum bundle. Are those the cingulum bundle? Well, I don't know. I guess it depends on your definition, but the point is that they're there. And they're there when you're stimulating with your DBS electrode. They're there when you're doing your ablations. So we came up with two different definitions of tracts that we think can help a bit. One is a volumetric definition of a tract. And in this case, a tract is defined as coursing through a specific white matter volume. So the corpus callosum would be defined as, any fibers that go through that little piece that's sort of right in the middle of the brain, right? A connectionist definition of a tract, on the other hand, the defining features are the regions that the tract connects to. So the origins of the fibers or the terminations of the fibers. So to make this clear, a little bit clearer, I want to go back to the anterior limb of the internal capsule. So the volumetric definition of the anterior limb of the internal capsule is that it is the white matter lateral to the caudate, medial to the putamen, and globus pallidus. The connectionist definition of a tract is that it is the fibers connecting the prefrontal cortex with the thalamus, brainstem, and subthalamic nucleus. Now, you might think, aren't these 99.999% the same? Are these really in tension with each other? They are, because there are a whole bunch of fibers that are volumetrically present in that space, lateral between the caudate and the putamen, say, that are not prefrontal descending fibers or ascending fibers, such as striatopallital fibers and especially intrabasal ganglia fibers. They're in that same volumetric space, but are they anterior limb of the internal capsule? Well, again, it depends on whether you're taking a volumetric definition or a connectionist definition, but from a DBS perspective, the important thing is that they're there. Right? So we need to have a complete picture of which fibers are present at any given location. All right, so I answered the first question. How do we build a wiring diagram of the brain with a multimodal cross-species approach and with attention to this volumetric versus connectionist way of looking at specific targets? Now, why? Why should we build a wiring diagram of the brain? What if we just never knew which regions are connected to one another? Or maybe like what we've got now is enough. I could see thinking that maybe. I would like to try to convince you that anatomical connectivity in particular can provide a bridge between the sort of macro-scale cortical networks that we can get in humans and that are important for understanding and treating psychiatric disorders to the micro-scale functional circuitry and mechanistic studies that we get out of non-human animal models. So first, I'm going to sort of cover three topics all very briefly here. Let's talk about figuring out what parts of the brain are what across species. All right, so this problem began when I was a postdoc with Suzanne Haber at University of Rochester, and Jose Rodriguez Romaguera, who's now faculty at UNC, and Greg Quirk, who was then at University of Puerto Rico, came to visit the lab. And what they were trying to do was model this specific hypoactivation in the post-traumatic stress disorder patients that people had observed again and again in the dorsal anterior cingulate cortex. They wanted to model that hypoactivation in the rat and then optogenetically manipulate the connection between the amygdala and that spot and the striatum. And so they came to us and they said, hey, what's that spot in the rat? And I was like, uh-oh. Uh-oh. So the reason why I said uh-oh was not just because rodents themselves are so important to understand, or rodents, that they're interesting on their own, but of course they provide an essential platform for the neuroscience studies, the mechanistic studies that aren't possible in humans and are not even possible in non-human primates. And that means that knowing homologies, or which parts of the brain are shared versus different across primate, including human, and rodent brain regions is really fundamental for translational research. And in the case of the prefrontal cortex, this is especially difficult. And that's because the entire prefrontal cortex in rodents is what's called agranular, meaning it lacks a layer 4. Whereas in primates, monkeys and humans, there are some granular regions, meaning they have a well-defined layer 4. There are some agranular regions, no well-defined layer 4, some dysgranular regions, everything in between. And so it's been a real hot-button issue. What is the prefrontal cortex in rodents? Is there any one-to-one correspondence? They certainly have stuff in the front of their brains. What is it? So what we wanted to do was have a conserved structure, a structure that was relatively similar across rodents and primates, and we were asking about connectivity with that structure because we wanted to bring new data to bear on this problem. And so we analyzed the anatomical projections of specific prefrontal regions, the anterior cingulate and the orbital frontal cortex, to the striatum to infer cortical homologies. And we used rats and monkeys, but it's not such a huge leap, as I already described, to go from monkeys to humans, and how I won't describe. Not such a huge leap to go from rats to mice. And we created a series of connectivity profiles that I don't have time to show you here, but it's been published. And what we made out of that, we hope, was the beginnings of a roadmap for how to translate results between primates, including humans, and rodents. So, for example, if you have a finding in the subgenual cingulate, area 25, of the non-human primate or even the human, that should be modeled in the infralimbic cortex of the rodent. And if you don't know what that means because you're not a rodent researcher, that's fine. The point is that there's a spot for you to go. The same thing if you have a medial versus lateral finding in your orbital frontal cortex of one species, that should be transferred to the medial versus lateral orbital frontal cortex of another. But of course, not all regions in the primate are going to be perfectly represented in the rodent, and that's true especially for more dorsal anterior cingulate cortex regions, and I'm happy to talk more about that offline. So what that did was let us use, so we used that, I'm asking why should we build a wiring diagram of the brain? I think that the wiring diagram gives us a sort of, the data that we need to answer these questions about homologies. I want to talk about a different brain region, the posterior medial cortex, and what anatomical connectivity can say about its, about structure-function relationships there. So the posterior medial cortex is in humans and macaques, the posterior cingulate, the precuneus, and the retrosplenial cortex. Probably most of you haven't heard of it, but if you have, it's because it's the hub of the default mode network. And the way that most people have studied the posterior medial cortex in the rodent is based on its connections with the medial temporal lobes. And so there's a rich literature of the posterior medial cortex functions in navigation and associative learning. But more recently, we've understood that it seems to have a role in decision-making. But knowing what that role is has been very, very elusive. And we haven't been able to put it into a really great context yet. Whereas we know a lot about frontal and subcortical roles in decision-making, especially frontal striatal roles. So there's sort of this, there's sort of a canonical understanding of the striatum. This is definitely oversimplified, but the dorsomedial, dorsolateral striatum and the ventral striatum have different roles in decision-making. And so we ask, where structurally would the posterior medial cortex fit into that? And the answer is very easy. It's just into the dorsomedial striatum. The connectivity of the posterior medial cortex in the rodent is almost entirely with the dorsomedial striatum. So the goal here is to say, okay, this is kind of the framework for how you should think about the posterior medial cortex and its roles in decision-making. And we have done some of that work. So the connectivity of the posterior medial cortex and the rodent with the orbital frontal cortex is actually well mirrored in the non-human primate. And we sort of recorded in these structures simultaneously the orbital frontal cortex and the posterior medial cortex, and found some major functional differentiation such that the connected part of OFC had high functional connectivity with the PMC, which is good, right, a validation. But we also found that that connected part of OFC seemed to encode value information that it transferred to the posterior medial cortex, which then added spatial information. And this relationship was not true of the sort of unconnected part of OFC. And so this is one way to sort of examine circuit function in non-human primates. I do just want to touch more on neuromodulation and, more directly, hopefully you've seen the relationship throughout. You've seen this figure already from Patricio Riva-Posse. This was instrumental in understanding that it was the confluence of three white matter targets that was necessary for effective DBS of the subgenual cingulate cortex. And at the same time, we've been working to elaborate what are the actual connections that are present there, because it is, it is three fiber tracts, but what is present in those fiber tracts, and what else, as I said before, is there if you take a more volumetric approach. I will end with that and say thank you to all of my collaborators, the members of my lab, and my funding sources. Thanks for having me.
There we go. Microphones should be going around. Anyone? Yes, no, maybe? So, while we're waiting for a question from the audience, so maybe taking it back to what you said at the beginning, and again, this sort of link with some of the stuff that the previous two speakers were talking about is and I'm thinking about that sort of yes/no decision tree slide that you showed at the beginning, right? That tells us the rules. That tells us the atlas. And how are you thinking about how we then use that for the clinical problem that, don't talk with your hands. The clinical problem that so many of us are facing of, okay, that's the atlas, but where is it in my individual patients? How have you started to think about how this work extends in that direction?
Yeah, I think that once the rules are adhered to, the individual tracks are likely going to be quite accurate. And I think that we'll be able to show that in the monkey, and that we'll be able to also validate it with the kind of stimulation, structural connectivity combination within subject things that Kelly showed. I think that that the types of errors that I see diffusion tractography making are sort of all or none type errors. And once you say, oh gosh, don't go down that road, that's a terrible road. Once they're on the right road, they can get to the destination. But that's an empirical question.
We still got time for one or two. There's one back there.
Hello.
There we go.
Thanks for a great talk. I was just curious if you could comment at all on how the connectivity you're looking at compares to effective connectivity from evoked potentials and intracranial recordings.
Yeah, so that's exactly what the brain stimulation paper that Kelly previewed is on. I will say I have, aside from that paper, which shows some relationship, like a strong relationship between structural connectivity as measured through tractography and evoked potentials, but remember that the tractography may not be totally perfect, so it's a little hard to know. I will say people have done a lot of work looking at, not a lot of work, a little work, looking at the relationship between track tracing and resting state functional connectivity. And often those correlations are just as high as track tracing is with tractography, which is not ideal because we know that resting state isn't supposed to be monosynaptic, right? It's supposed to show these sort of multi-layered networks. And so that's a different problem that people, mostly in rodent models, are trying to work out which exact layers and sets of oscillations are contributing to resting state fMRI. But for now, it's not dramatically worse performing in terms of its relationship with anatomical connectivity than structural connectivity is.
Thank you.
And we have a question up here from Dr. Mark Thomas.
Great talk, Sarah.
Thanks, Mark.
So this maybe relates a little bit to the last question, but is there anything interesting in those errors?
Which errors?
The errors that between the discontinuity between the anatomical and
the resting state or the structural?
No, the structural.
Oh, the structural. Yeah. Is there anything interesting? Well, once I've determined an error, I would say no. And it's usually not hard to, but those other areas that are potential species differences, that's extremely interesting. But I will say it's usually not hard to tell where the error comes from. There will be like major crossing fibers or fanning or catching fibers or curving or something's going on that you can usually kind of tell what went wrong there.
Okay. Got it. Thank you.
Cool.
Anyone else before the break?
I'm all that's standing between you and cookies.
Yeah, I know that's always our problem. If not, we will thank Dr. Heilbronner again. And I will echo Dr. Netoff that there is coffee outside, but also our fine sponsors and vendors would love to talk to you about how they can make your research even better.